Good afternoon. My name is Melaina Munson, and I'm a sophomore chemistry student. Today, I'm excited to talk to you about my research projects, oral paclitaxel nanoparticles for long-term ovarian cancer management. I've had the pleasure of working on this project this semester under the guidance of my PI, Dr. Arora. So why ovarian cancer? Well, we see that ovarian cancer simply is the uncontrolled growth of abnormal cells within the ovaries that have the potential to metastasize or travel to other areas of the body. It is currently the 8th most common cancer in women worldwide and accounted for 21,000 new cases just this year in the United States alone. Despite being the 8th most common, however, it is the 5th leading cause of cancer deaths amongst women. This indicates to us that we are not as good at treating ovarian cancer as we are at treating other forms of cancer and makes it a research priority for better treatments. The current standard of treating ovarian cancer starts with surgical excision of any abnormal cells, which is often followed up by radiation therapy. Next, a treatment approach called maximum tolerated dose chemotherapy is used, where the highest possible dose of 2 chemotherapy drugs that a patient can tolerate, paclitaxel and a platinum-based chemotherapy agent, are given. This is given once every 3 weeks as an infusion. We see really severe side effects from this treatment approach because of the extremely high doses of drugs used. Additionally, there are high rates of cancer recurrence and drug tolerance, which can likely be attributed to the long periods between drug dosages. A promising alternative treatment path is called metronomic chemotherapy. Metronomic chemotherapy gives small doses of these drugs daily and has multiple different mechanisms of action. We see angiogenesis effects, which inhibits the formation of new blood vessels to the tumor, effectively starving it up. Immunomodulatory effects, which increases the body's natural immune response to fight off cancer cells, as well as direct cytotoxicity. This is extremely promising as we see much lower rates of side effects amongst patients and improved quality of life, as well as decreased rates of cancer recurrence and drug resistance. When looking to study these treatment mechanisms, paclitaxel was identified as our drug of interest. It is an antimicrotubular agent that inhibits the proliferation of cancer cells. It is the first-line chemotherapy agent for breast, non-small cell lung cancer, and pancreatic cancer, as well as ovarian cancer, which makes it an extremely interesting drug to research because of its widely used applications. Currently, it's only available for intravenous administration primarily and is given at a dose of 175 milligrams per square meter as an IV infusion for 3 hours once every 3 weeks. There are a lot of issues with the IV administration of paclitaxel, the first being that on its own it is not soluble and it must be bound to something. It originally was bound to Krempfer-EL proteins, but we found anaphylactic reactions to this. This was solved by Abraxane, an albumin protein-bound chemotherapy agent that prevented these reactions. Additionally, any administration of an IV medication carries a lot of risk, especially of infection, which is particularly to note in many immunocompromised cancer patients. Additionally, it is extremely time-consuming and resource-intensive to visit these infusion centers regularly and creates a lot of difficulties in accessing care. Finally, if you look at the concentrations of an IV infusion, you see a really high peak concentration initially after administration that is rapidly eliminated from the body, and these don't allow for metronomic chemotherapy schedules currently. The solution to a lot of these problems would be an oral formulation of paclitaxel. In an oral form, patients could take this medication at home, avoid hospital visits, which would improve patient compliance and access to care, and additionally would allow us to explore metronomic chemotherapy options, which have shown incredibly promising. So, oral formulations of most drugs are considered the gold standard. Why don't we have one of paclitaxel? And that is due to its poor bioavailability. You can think of bioavailability as the fraction of drug that actually reaches the bloodstream in target organ or tissue. Currently, when paclitaxel is taken, it goes from the stomach to the small intestine. Instead of being absorbed in the intestines, we see P-glycoprotein efflux pumps that actively eliminate paclitaxel from the body. The small portion of the drug that is absorbed first goes to the liver, where it is rapidly converted into an inactive form of the drug, which is known as high first-pass metabolism. My research focuses then on combating this poor oral bioavailability using polymeric nanoparticles. Our polymer of choice will coat these drug particles, protecting them from degradation and rapid metabolism within the liver. Additionally, gambogic acid is a ligand that is attached to this polymer and then is able to bind to transferrin receptors within the small intestine, increasing the uptake of the drug through non-competitive uptake. This allows for receptor targeting as well, increasing cellular uptake of the drug. To start my research, I first focused on synthesizing this polymer. The first step is creating the polymer backbone. A polymer can be thought of as a repeating chain, so for our backbone, we see a repeating chain of PEG, PLA, PEG, and a chain. This first reaction is a 24-hour reaction that occurs under heat and nitrogen gas, as seen in the setup to the right. It must occur under nitrogen gas because moisture is extremely harmful in this reaction. Once the backbone is created, I did another 24-hour reaction where a dianhydride linker was attached, which acts as a site where we are able to attach further functional groups. Next, N-Bach ethylene diamine is first attached and then deprotected to create a free amine site. This free NH2 group is then able to conjugate with gambogic acid, creating the final polymer. Throughout the process, it is extremely important for us to regularly characterize our polymer through a variety of techniques to make sure that the reaction has occurred properly. We use nuclear magnetic resonance imaging to look at the structure of the polymer, as well as gel permeation chromatography to look at the molecular weight of the polymer. In the chart above, you can see that between the pre-polymer and P2S phase, the molecular weight has approximately doubled. This shows appropriate chain extension by adding the dianhydride linker. This molecular weight is also important for calculating stoichiometric ratios for further reactions. Once our polymer is successfully made, then we move on to making formulations of it with paclitaxel. For my formulations, I made two different formulations, one just using the P2S polymer and the other using the P2S gambogic acid polymer. The polymer and paclitaxel are added together to create an organic phase, and water and PVA create the aqueous phase. Next, the organic phase is added dropwise to the aqueous phase and then homogenized. Homogenization is a really strong blending process that creates extremely small particle sizes. After homogenization, we add the mixture to water and allow the solvent to evaporate. From here, we're going to test these particles with diffraction light spectroscopy to characterize their size. Next, we centrifuge it down, creating a supernatant in a pellet. The pellet contains most of the concentrated drug nanoparticles, and we test it using HPLC to determine the drug concentration. Looking at the nanoparticles that I created, the P2NS paclitaxel particles and the P2NSGA paclitaxel particles, you can see the size for both of them is below 350 nanometers. This is extremely important as any larger particle sizes than that will not be able to make their way into the cells. PDI is a measure of the consistency of particle size, and you can see here that a value closer to 0 indicates more consistent sizes. The zeta potential needs to be around 20 to 30 in order for the particles to not clump together too much, and entrapment efficiency allows us to calculate how much paclitaxel that we added actually made its way into the particles, and then we use this information to calculate dosing. Moving forward, my next steps are an in vivo study of paclitaxel using a syngenic mouse model. This means that we are going to inject immunocompetent mice with mouse ovarian cancer cell lines to give them ovarian cancer. Next, we will study the efficacy of our paclitaxel nanoparticles and determine if they are effective. I will now be taking questions.
So on slide 8, you began to talk about the width of the coating and the need for that for the degradation issues. So how did you come about to know the width again? And does that also would that depend on the individual? Maybe someone's stomach acid levels or something like that. Is there some way that there's even customization when we do these kind of deliveries, or is that just? This is a really naive question, right? So
No.
It's like how do you determine the width of that coating?
Yeah, so The size of the particles is extremely important because in studies we have found that anything above 350 nanometers will not make its way into the cells. The body can recognize it as foreign and it has a lot of mechanisms to get rid of it. So we find the size through diffraction light spectroscopy, which measures how much energy these particles are absorbing, and that gives us the size of them. As far as customization, size-wise we don't customize, but there is customizations possible in the amount of gambogic acid that is added. We can customize those stoichiometric ratios to really get the correct absorption rates and therapeutic levels of the drug in the bloodstream that we want.
On slide 4, you mentioned paclitaxel can be used for pancreatic cancer, but you also mentioned, in addition to ovarian cancer, breast cancer. So are there something special about that for the kind of cancers that women would experience? Or maybe this is beyond the scope, but is there, you mentioned at least 2 things there that are there other kinds of cancers that were useful, or are these mostly helpful for things women would experience, and why would that be?
I'm not entirely sure on why they seem to be particularly effective in cancers in the female population, but we do see them. They work as an antimicrotubule agent. So inside of your cells, these microtubules are what allow for cellular division and appropriate division during mitosis. And so it's preventing that cell division so that the cancer cells don't grow. We also see it effective in pancreatic and non-small cell lung cancers. And so generally, it's fairly effective at treating a wide variety of different cancers. And that's kind of why we identified it as a great drug to study, because of all of its different applications.
When you were talking about the zeta potentials there, I noticed that you said like a good value was around 20, but one of them was positive and one of them was negative. Can you explain why that is, and if they're the same thing, if they're positive or negative?
Yeah, so the gambogic acid that is added in the second polymer that's positive is what conveys that positive charge. And so we expect them to be around similar values between 20 to 30, and the P2NS polymer to be negative and the gambogic acid to be positive.